Well, first of all, I wish Jack Schuberth would be a little more opinionated so we know where he stands in these controversies. I will be the opposite. I'm going to be very wishy-washy. No evidence base on this, a lot of just blind speculation, but here we go. This is really, it's kind of similar to what Jack shared with you yesterday. This is the culmination of my 33 years in clinical practice, and a lot of things that influenced me and challenged me brought this whole lecture together. So I'm going to kind of take you through a little journey. And it actually started here with Mert Root. I showed this picture yesterday in my workshop. Someone commented that the suit looks like a scene out of Mad Men. That was back in 1963. Of course the suit would look that way. But Mert Root had an influence on me, and for one reason was I co-authored the last paper he ever wrote. And this was a study of range of motion of the first ray, where we were trying to validate Hicks's original theory of what the axis of the first ray was. It had been challenged by some podiatrists from New York who said it was exactly the opposite. And so we did a cadaver study, and indeed found that Hicks was right, that the first metatarsal does dorsiflex and invert. And that was my first experience in a cadaver lab and dissecting a lot of cadavers and looking at this first ray and looking at the arch of the human foot. And it led me on a journey to take you to where this lecture really is today. The other part of it is what I shared with you yesterday. It's treating a lot of patients with plantar heel pain and failing with that treatment and trying to figure out what it is that overloads the plantar fascia. And as that journey evolved, it also took me into looking at arch mechanics and the first ray. And so I want to take you through some really landmark papers and research and basic science and anatomy to understand where I am in my understanding of the arch of the human foot. So let's look at the points of confusion about the first, about the plantar fascia. I went over this yesterday, and that is, what is it and what do we tell our patients occurs that makes the plantar fascia be overloaded and make them develop heel pain if it's due to plantar fascia overload? And one of our favorite mechanisms is to blame it on pronation of the foot or excessive pronation. And so the first paper that's really had a big influence on me is this paper by Sarafian. And he published this in the late 80s in Foot and Ankle International. And I'm going to come back to this paper several times during my presentation. But the first part of what Sarafian did, he was trying to show what happens to the plantar aponeurosis and what the human foot does to load it or offload it. And he took a simple cadaver and he internally rotated the leg. That's what IR stands for up there. And as he internally rotated the leg, he observed, as he describes here on the right-hand side, that the plantar aponeurosis becomes taut, as does the abductor hallucis. And he took that same cadaver and he externally rotated the leg, which supinates the foot, and he noted that the plantar fascia became, as he says, loose or undulant. And so this was pretty clear graphic evidence that as we pronate the foot by internally rotating the tibia, we cause overload or tension on the plantar fascia. So patients like this who have a pronated foot are thought to overload their plantar aponeurosis. And if we can stop that pronation, we theoretically offload the plantar aponeurosis. But it's really not quite that easy because, first of all, the word pronation and pronation of the foot has always been confusing to me because there's more than one joint in the foot. And when that foot on the ground is pronated at the subtalar joint, it is usually supinated at the mid-tarsal joint. Because as the hindfoot everts, the fifth metatarsal never comes off the ground. It stays on the ground because reciprocally the forefoot inverts on the rear foot. And so instead of the foot looking like this when it's resting on the ground, the forefoot inverts to become plantigrade in almost every case. And so when we pronate the subtalar joint, which is what Sarafian did in that picture, we also influence the mid-tarsal joint in a supinatory rotation around the mid-tarsal joint longitudinal axis. This was validated in a very important paper by Paul Scheer and a group of students at the California School back in 1988. And they took a fairly large number of patients who presented with plantar heel pain. And among other things, they treated them with conservative measure. But they looked at their foot type. And they found that 80% of those patients had a foot deformity, so to speak, that compensated by supination of the forefoot on the rear foot. Those three foot types would be either a forefoot valgus, an everted rear foot, which I showed you earlier, a fully pronated subtalar joint, or a plantar flex first ray. All three of these foot types will cause the foot to compensate in stance by supinating around the longitudinal axis of the mid-tarsal joint. These three foot types. So Scheer speculated that there was some kind of motion with the forefoot on the rear foot that tensioned the plantar aponeurosis and made these patients more vulnerable to heel pain. But he really didn't go any further to prove that. He didn't go in the lab or do any other studies. Until this. This is a really important paper in my mind because it really opens up a whole new thinking about what happens to the plantar fascia. This paper actually won the Basic Science Award in JBJS the year it was published. And it's published by this fellow named Kogler. And Kogler is a PhD mechanical engineer, but he's also a certified orthotist. And what he wanted to do was to determine the effect of wedges placed under the foot and how it might influence strain on the plantar fascia, particularly at the location that most people get plantar heel pain. So what he did is he took 9 fresh frozen specimens and he applied axial load. And he took, these are 6-degree wedges, so they're pretty ambitious. And he placed them in one of 4 locations in the foot, either forefoot medial, forefoot lateral, rear foot medial, or rear foot lateral. And then he measured the strain or the change of strain in the plantar aponeurosis once the wedge was placed under the foot and axial load was applied. So here's his testing apparatus. Now, a couple things just to note here is this is a static cadaver model. It's not a dynamic model. And so there may be misinterpretation or alterations of how this will work, but it still shows us something that I think is interesting. Now, in the United States, the favorite wedge to put under the foot, or the favorite post to put on a foot orthotic, is a varus post. That's the favorite. And I give this lecture a lot in front of podiatric audiences, and I say, if you were going to put a wedge under the foot of a patient and try to offload the plantar fascia, how many of you would use a medial wedge? And it's overwhelming in the audience. And then I would ask, where are you going to put it? And some people favor putting it in the forefoot and some in the rear foot. In podiatric labs, it's routine for podiatrists to usually prescribe a forefoot varus post to control the foot. Okay? The valgus wedge, the lateral wedge, is not that commonly prescribed, particularly with foot orthotics. But that's the wedge Kogler put under the forefoot, 6 degrees. Now here's the results of the study. In every case, when a forefoot medial wedge was placed under the cadaver, it increased strain in the plantar fascia. And in every case, when a lateral forefoot wedge was applied, it decreased strain. Quite the opposite of what most people would expect. And when he put a rear foot wedge, whether medial or lateral, it had no effect. So here's the statistics. Rear foot wedges had no significant effect, but it was significant when a forefoot lateral wedge was placed under the front of the foot, or under the plantar surface of the metatarsals. Kogler really didn't go much further to explain why that was. He just reported the results. And so when I was putting together this lecture 10 years ago, I went back to Serafian's model to see if maybe there was another explanation. And here came this whole concept of what we call the twisted plate theory. Serafian in that article used that description of the human foot, or the skeletal relationship of the foot, as a twisted plate. He observed that the bones of the rear foot, the talus and the calcaneus, were, as he says, compressed or oriented vertically, while the forefoot bones, the metatarsals, were oriented horizontally. and that in between these two segments, a twist had occurred in the skeleton. And Serafian showed that if you wanted to further twist the plate, you would actually raise the arch of the foot. And he showed, as I'm about to show you, that as he inverts the heel, or the calcaneus, it raises the arch of the foot. Now that's a concept that most of us are well familiar with. But what's interesting from Kogler's work is it's almost the same result if you evert the forefoot, because it also twists the plate in the same favorable direction. Okay? So this twisted plate theory that I read for the first time from Serafian, as I'm about to show you, was not proposed by Serafian at all. It was proposed by a brilliant Irish anatomist. Irish anatomist, of all things. And the twisted plate theory, to consolidate this whole lecture in one statement, is that if you twist the plate favorably, you will raise the arch of the foot, the medial longitudinal arch. You will plantar flex the first ray. You will decrease strain in the medial central band of the plantar aponeurosis, and you will decompress and improve range of motion of the first metatarsophalangeal joint. Every one of those things are goals of podiatric foot orthotic therapy, and most of those are pathologies that we treat on a daily basis, right? So if we could learn to do this, we could cure most foot pain that comes in our office. This is somewhat tongue-in-cheek, of course. So who described the twisted plate? It was first described by McConnell. And Serafian in that article didn't mention McConnell, but I got Serafian's textbook, and especially his newest version, and he gives great credit to McConnell. He goes into great detail about what McConnell first said and how he described it. And so I was able to get the paper on microfilm, but it was published in 1945. And McConnell introduced this term lamina pedis. Are you familiar with that? Okay. I mean, because I'm lecturing to a British audience, maybe this is old hat to you. Martin, have you heard of this? Okay. Later, McConnell, and much later, it's quite interesting, the paper was 1945. 20 years later, he teams up with Basmagian, who's an eminent electrophysiologist and EMG guy, and they wrote a book in 1969 talking about muscles and movement, and McConnell and Basmagian talked again about the twisted plate. And then finally, Serafian brings this up again in his article in 1987, and it's also in his textbook. But here's McConnell's paper, and if you love reading great prose and great text, particularly from Irish, this is a great paper to read. And the first paragraph says it all. He says, the bones and ligaments of the human foot form a twisted osteofibrous plate of irregular thickness. The degree of torsion of the tarsometatarsal part of the plate is alterable. The torsion of the foot skeleton is brought about in intrauterine life. And then he proceeds to describe in detail his anatomy studies of these specimens. So that brought up a question. It occurs in intrauterine life. And I found this picture in another anatomy book showing a very early embryo. This is a picture of the human embryo at about 4 weeks, and this is at about 9 weeks. And indeed, this is a flat plate. The talus and the calcaneus lie next to each other. And lo and behold, in a matter of 4 to 5 weeks, it twists on itself. The talus and the calcaneus now lie on top of each other. And so this is what McConnell was describing that occurs in utero. Now, if you believe that ontogeny recapitulates phylogeny, you will say that this also would be depicted as we look at the evolution of the foot and look at the some of the studies and things that Peter Cavanaugh referred to earlier today. And I'm going to take you to that in just a moment. Another thing that McConnell described is this acetabulum pedis. This is very interesting. He looks very closely at the talonavicular joint, as well as the articulation of the anterior middle facet of the subtalar joint. And he talks about the importance of this relationship of the head of the talus sandwiched up against the navicular and rotating on these two facets. And he believes that's where everything is going on in the foot, not in the posterior facet of the subtalar joint. And he says that when we talk about the subtalar joint, we should really talk about the subtalar joint complex, which involves the articulations of the posterior facet, the middle and anterior facet, as well as the talonavicular joint. They work together. And in more recent kinematic studies, that's proven to be true. Here's the book that they published 20 years later. I looked for that in our medical library and I couldn't find it, so I went on Amazon and I bought this book for $5. It was in the Santa Barbara library and they sold it because nobody ever checked it out. And indeed, in that book, there's the twisted plate. Okay? Now, one thing that's interesting that McConnell talks about, and I thought it was interesting hearing Jack talk about ankle arthroplasty yesterday, is this fascinating relationship of the talus inside of the ankle joint mortise. And McConnell goes into great detail about that. And he talks about the fact that the lamina pedis, it doesn't involve the talus. The talus is housed in the ankle joint mortise, and this lamina pedis is everything distal to it. It's the calcaneus, then the navicular, the cuboid, and then the forefoot bones. And this brings up this other concept similar that was proposed by Kalikian called the two-lever theory. And again, it talks about the fact that the talus is so firmly housed in the ankle joint mortise that it moves with the leg, and that everything distal to it is actually subjected to the force of the leg driving the talus, and then the foot is kind of an innocent bystander because it's weaker. It has multiple joints and they're small bones, and the talus is carried by this massive tibia, which carries the bulk of body weight. McConnell points out, this is a good trivia question for your students, that the talus has 7 articular surfaces. It's basically a bone that's entirely covered with articular cartilage. What are these 7 articular surfaces? 2 on the tibial side, 1 on the fibular side, 1 on the inferior surface for the posterior facet of the subtalar joint. Then we've got that middle and anterior facet, and finally we have the talonavicular surface. Very interesting. Again, he talked about this subtalar joint complex. It's much more than just the posterior facet of the subtalar joint. He talks about this acetabulum pedis, and he talks about the interconnection, and we'll get to this later, through the interosseous talocalcaneal ligament. And then we get to this fellow. This is another British anatomist named Lewis. I don't know if any of you have ever read his work. But Lewis took McConnell's work, and I think Lewis was a comparative anatomist, and he went back and looked at other primates and compared this twisted plate configuration of the human foot to other primates. And this is where the embryology of the human foot compares to the comparative anatomy, or the evolution of the human foot, so to speak. And his paper is quite interesting too, and it was written much more recently in 1980. And what Lewis does is talk again about the lamina pedis, but he looked at other primate feet. And he showed, and I'm going to show you in a second, that primates don't have a twisted plate. Their bones lie in a flat plane on the ground. Okay? And so as we look at these primate feet that have no arch and very little stability, we start to get an understanding, perhaps, of what happens in the pathology, in my interest, the adult acquired flat foot. So on the left is a human foot, large heel bone, the ankle's adapted for walking. It has a stiff midfoot, a stable mid-tarsal joint for propulsion. And of course, the hallux is brought into adduction to provide a weight-bearing beam. The right-hand picture is a chimpanzee foot, small heel bone, more adapted for climbing, very flexible midfoot, and a grasping hallux. So this is the difference between the primate, particularly the chimpanzee foot at mid-stance versus the human, and the efficiency gained by the arch configuration providing a stable lever for propulsion. But as I showed you yesterday, there's human feet that look like this after the spring ligament is ruptured and after the posterior tibial tendon is ruptured. These are skeletal models of a human foot compared to the primate, the chimpanzee foot, and this looks like the radiograph of the adult acquired flat foot. So Lewis took various specimens of primate feet, and he looked at the relationship of the talus and the calcaneus, and just to jump ahead, in almost every case it's all a flat plate. The talus lies medial to the calcaneus, and look at the posterior facet of the subtalar joint. It is oriented in a vertical arrangement because the two articulate side to side instead of on top of each other. So this places the subtalar joint axis in a much different attitude than the human foot. And so what Lewis did was he took this, this is some type of New World monkey, and look at this facet of the subtalar joint. It's oriented side to side for the talus. It's been disarticulated here. And it places the axis extremely medially deviated, as we see in an extremely pronated foot. And he shows these other primate specimens and how the talus and the calcaneus interact with each other and how the subtalar joint axis gradually begins to move over and assimilate what the human foot has. Okay? So what we see as this lamina pedis twist in a favorable direction to establish the arch of the foot is that a lot of it has to do with the rotation of the head and neck of the talus, which occurs in utero. And we can see this if we go back and study the embryology of the human foot. Here's a very early embryo, just a few weeks. Here's the twisting of the plate. We start out, this is a human foot. Talus is lying here, and the calcaneus is immediately next door. It's articulating side to side, not on top of each other. Here is the talus, and look at, this is a human foot now, embryonic. The subtalar joint is oriented in a vertical plane, just like in the primate foot, and the calcaneus lies over here next door. And then we look at the position. Here's the position of the human foot in utero, and this was a fascinating study where they looked at the relationship of the forefoot to the rear foot in the embryo, and in every case the forefoot is inverted on the rear foot 30 to 45 degrees. It has a huge forefoot varus in utero, and then by the time the fetus is born, the forefoot has rotated out of supination into a pronated alignment on the rear foot, twisting the plate in utero. The forefoot pronates, first ray drops down, and if everything works out great, we have a perpendicular forefoot to rear foot. This later in life, the first few years of life, the head and neck of the talus undergo even more torsion. And you've read about this. This is the torsion of the head and neck of the talus in the direction of pronating the forefoot on the rear foot. Pronating the forefoot on the rear foot, taking it out of supination. Also, interestingly, the head and neck of the talus rotate from an adducted position to an abducted position. Okay? This is all from Lewis. And we're going to come back to Serafian now and make this somewhat clinically relevant. Okay? Serafian explains the stability of the human arch to this well-known truss mechanism, where the truss, just in a simple engineering term, describes the talus on top of the calcaneus forming a proximal strut, and the first ray of the human foot forming the distal strut, and they're connected by a tie rod, which is under tension as it maintains the height of the truss. And as we twist the lamina pedis, that is, twist the forefoot on the rear foot, we see changes in that truss mechanism, and particularly in the tension of the plantar fascia. Twisting the lamina pedis in a favorable way means pronating the forefoot on the rear foot. And untwisting the lamina pedis means supinating the forefoot on the rear foot, taking it back more to what the primate foot is. Here's Serafian's picture showing that as we supinate the rear foot, the forefoot pronates. That's a favorable twisting of the arch, or twisting of the plate. And in contrary, as we pronate the hindfoot, and I showed you this with Paul Scheer's work, the forefoot supinates. And as Serafian shows here, the plantar aponeurosis develops tension. So as we're twisting the plate on each other, we bring into play other people's theories of what makes the human foot stable. And one thing I was always versed on that Mert Root preached all the time was this so-called locking mechanism of the mid-tarsal joint. And that really wasn't his mechanism. It was really described by Manter before that, where they looked at human specimens and then they looked at the skeletal model, and they decided that yes, as the foot everts at the hindfoot, it unlocks the axes of the talonavicular and calcaneocuboid joint, and it allows more motion. Okay, well that's untwisting the plate. Evert the heel, the forefoot supinates, you've untwisted the plate, and indeed we look at human patients in our office and they have a more flexible forefoot to rear foot. People challenged that for a while, but with more modern kinematic studies, this was done up in Seattle. Blackwood's paper, which I've quoted a lot in my lectures, validated that there actually is a mid-tarsal joint locking mechanism that occurs in dynamic gait. And they concluded that using sensors, they were able to quantify differences in forefoot motion as related to calcaneal positioning. Basically, there is more forefoot motion when the calcaneus is everted, untwisting the plate. So untwisting the lamina pedis takes us back to really what those pathologic feet look like that I showed you yesterday, the adult-acquired flat foot. Because if we look at every part of that adult-acquired flat foot, even radiographically, we see the widening of the talocalcaneal angle. We see the supinatus deformity that I showed you yesterday. That's an inverted forefoot on the rear foot. It's a untwisted plate. I showed you the difference of stable feet when the ligament complex is intact compared to pathologic feet that break down at the mid-tarsal joint. That's a primate foot. This is a healthy human foot. This is a human, but it looks like a primate foot because the mid-tarsal joint is severely unlocked and subluxing in the sagittal plane. That's a untwisted plate. Everted calcaneus, a severely unlocked mid-tarsal joint, and if we take her off weight bearing, we see a supinated forefoot on the rear foot. That's a untwisted plate. I showed you this interesting radiograph. It's a standing AP view of the hindfoot, where if this doesn't look more like the primate foot, I don't know what does. That talus has shifted, or that calcaneus has shifted lateral to the talus, which is up here in the ankle mortis. It has shifted lateral, and it hasn't everted. Okay? Look at this radiograph. It gives the appearance that the calcaneus is everted, but it really isn't everted. It's shifted lateral, or more importantly, the hindfoot is shifted medial. That looks like a primate foot. If we look at the radiograph here of the adult-acquired flat foot, we see the complete loss of arch configuration due to significant rotational change through the hindfoot and the forefoot. We can show this acquired forefoot supination by correcting the hindfoot to vertical, and when we do, the forefoot is inverted on the rear foot, and it has acquired that deformity because it has untwisted. That's an untwisted plate. Now, interestingly, Serafian tried to depict this and how the arch of the foot raises and how the foot actually shortens, but he took a piece of plastic and he took it and he twisted it, and as he twists it, you can see an arch form in the piece of plastic. And he measured the distance across the plate, and he noted the more he twisted it, the more the plate shortened. And he was just showing you this to say that's what the human foot does. When he untwisted the plate, he put a wedge under the front of the plate to untwist it, and that looks to me like a forefoot varus post. That looks to me like the same varus wedge Kogler put under his cadaver to increase load on the plantar aponeurosis. And when Serafian tried to twist the plate, twist it in a favorable way, he put a lateral wedge, just like Kogler did. There's the three appearances. So this plate has gone from an untwisted length of 23 centimeters to a twisted length of 20, okay? So I said, if that's true, we should be able to take a human foot and twist it and measure those same changes, okay? So here is my single subject design study. I took a single subject, my office manager, who had to volunteer for the study, and I picked her because she had to do it, and also because she has what I would consider a normal foot, if there is such a thing. Here's her forefoot to rear foot relationship, and as she has what we would call a pretty a normal relationship of the forefoot to the rear foot, okay? That's a tractograph there. Okay, you missed that one. And I took Kogler's wedge. Now that's a 6-degree wedge. Those are pretty ambitious, but I wanted to do it like Kogler did. So I put a 6-degree wedge under the lateral forefoot, and I took an X-ray of her in a weight-bearing position. And then I switched over, and I put a medial wedge under the forefoot, and I took an X-ray. Okay, and I wanted to see if the arch raised or if it got shorter like that piece of plastic. Okay? I had no idea what to expect. So here's her standard weight-bearing X-ray without any wedge underneath. And I think you would all agree this looks like a very normal foot. Perfect cyma line, pretty average calcaneal inclination angle. Everything is really healthy here. So I'm going to measure the length of her arch as defined by the distal margin of the head of the first metatarsal and the posterior margin of the calcaneus. And the length of her arch is 20.4 centimeters. So I'm going to put the medial wedge first under here. And here's my X-ray. Now here's what the medial wedge does. It massively elevates the first ray off the ground. It creates the biggest metatarsus primus elevatus you could ever imagine, right? It also, as you're about to see, lengthens the arch of the foot. And I'll show you the comparative pictures. And it has a calcaneal inclination angle of 20 degrees. Now I'm going to put the lateral wedge. This is the Kogler wedge. And here's the change. The calcaneal inclination angle increases by 5 degrees compared to the medial wedge, and the length of the arch shortens by 4 millimeters. So here's lateral wedge, here's medial wedge. Lateral wedge, medial wedge. So with one subject, we could twist the plate and show an actual change in the arch, the height of the arch, the elevation of the first ray, and the length of the arch in just one subject. This is the medial forefoot wedge that actually lowered her arch, elevated her first ray, and as Kogler showed us, increases load on the plantar aponeurosis. This is the favorable wedge, at least with that one patient, which does the opposite. Okay? Now let's bring this out more into real life scenario and how we could use this in the clinic. These are just little studies showing you what happens when you put wedges under the feet. When you put a wedge under the foot, it doesn't turn the foot. What it does is it increases pressure where the wedge is. It increases pressure. And these are a couple studies showing that. It doesn't make the foot pronate or supinate. When Kogler put that wedge under the forefoot, it increased pressure either under the first ray or under the lateral column. So if we want to extrapolate this, and now we're getting really speculative here, we could say that if we want to twist the plate in our patient in a favorable way, we will do a strategy that increases ground reaction forces under the fourth and fifth metatarsals, because that's what a lateral wedge does. And if we want to untwist the plate, all we do is the opposite. We put a wedge under the medial forefoot, which increases ground reaction forces under 1 and 2. Okay, now, we also know very simply by looking, if you looked at any foot on the ground and we evert the forefoot, well, I'm going to back up here. If we invert the rear foot, we will increase ground reaction forces under the medial calcaneus to do that. We'll put a wedge under the medial calcaneus to invert the rear foot. That's what the Kirby medial heel skive does, right? The idea is to put a varus ground reaction force and shift ground reaction forces medial to the subtalar joint axis to improve supinatory moment on the rear foot. Okay? But this is what's a little more different. Nobody's really looked at doing this to achieve almost the same effect. But then we went back to this guy, Mert Root, okay? And I got his lecture notes out, and I think of all the things Root did and said, and he was criticized, obviously, and a lot of people have questioned some of his conclusions about certain functions of the foot. But I think this was his biggest contribution, and that was what he described what a foot orthotic should do. And he says in this particular section, finally, a functional orthosis does not support the medial arch of the foot. The position in which the foot is casted for a functional orthosis requires that the mid-tarsal joint be fully pronated. With a properly made cast, the orthosis exerts no pressure on the medial arch throughout the stance phase of gait. This is really important. Root always played down the fact that foot orthotics were arch supports. He bragged about the fact that a properly made foot orthotic doesn't support the arch at all, and if it directly does push against the arch, it actually changes the foot in a negative way. What he felt was most important was that the forefoot be fully pronated on the rear foot. That's twisting the plate in a favorable way. That's putting a Kogler wedge into every orthotic we make. Okay? And to illustrate that point, I have this picture here. Now, this is great trivia. This picture is Jeff Root, the son of Mert Root, demonstrating the Root suspension casting technique. And this is, Jeff does it better than anybody because his father taught him this from the time he was a child, how to suspend the foot and fully pronate the forefoot on the rear foot and so-called lock the mid-tarsal joint. And to this day, I believe this works. And I'm more convinced after looking at all of these anatomic studies and speculation way before Mert Root that the human foot is more stable when the forefoot is everted on the rear foot. It's a favorable position. Now, if that patient has a forefoot to rear foot deformity, the Root orthoses will balance that deformity out through intrinsic cast correction. You're all familiar with this, right? And in this case, this is a negative cast of a right foot that captures a forefoot valgus. And after we correct that forefoot valgus, the hindfoot is perpendicular. And in this case, it was a lateral wedge effect of posting the forefoot to the rear foot everted. And then maintaining that nice contour of the cast. Now I'm going to show you something interesting. For those of you who have abandoned this methodology for various reasons, whether you believe in scanners, weight-bearing casts, overground scanners, etc., I want to show you just another really simple experiment that Jeff Root and I did. Jeff took his office manager, this is a requirement, and he casted his office manager one of three ways. The first way was the way his father taught him, the Root way. And then he put the plaster on her foot and let her semi-weight bear and push it into foam. Okay? Now in the United States, foam box casting is popular because it's quick and easy and no mess. Okay? And then some people like full weight bearing casts, so he did number 3, was a full weight bearing cast with full weight on the foot. This is the same subject, and it's her right foot in each case. And what we were interested in is what not only changes with the foot when we do that, but what the cross-section and shape of the foot is when we do this, okay? So this is what's interesting. She has a mild forefoot valgus. This is the Root suspension cast where when it rests on the surface of the ground, the hindfoot or the rear part of the cast is inverted. And that means she's got a everted forefoot to rear foot deformity, a forefoot valgus. When she puts that foot on the ground with just minor weight on it, now this is probably what happens with many scanners where the practitioner can't touch the foot. They push the scanning plate up against the foot. The forefoot valgus becomes a forefoot varus. Okay? And the reason is this does not load the mid-tarsal joint. It doesn't evert the forefoot on the rear foot. This literally untwists the plate. And it captures a deformity that's not really there. And what's interesting, when she fully stands on her foot, she captures a little less forefoot varus than when she's partially weight-bearing. And we can speculate for various reasons why that is. So Jeff, in his lab, and the Root lab in the United States is still open. It's probably the premium quintessential foot orthotic lab that his father started. This is how they pour up the cast. They will put a wedge under the forefoot, either medial or lateral, to neutralize the heel or set the heel perpendicular, and then they fill it up with plaster. But notice that in the Root suspension cast, a lateral wedge had to be placed under the forefoot to bring the heel to perpendicular. But when the patient bore weight, because it's a forefoot varus now, it's a medial wedge. Okay? Now, for those of you who believe in semi-weight-bearing casting, or who use a scanner where you cannot lock and load the mid-tarsal joint, just remember this picture. And go back. That is an untwisted plate, and that will end up twisting the plate favorably because it'll evert the forefoot on the rear foot. Okay? If you're just interested, real quick, I'll show you the cross-sectional analysis. This is what the heel cup of the orthosis looks like in a neutral suspension, semi-weight-bearing, weight-bearing. If you believe in the conformity of an orthosis to the anatomy of the foot, particularly to the calcaneus, remember that picture. And this is as we move forward into the foot. Capture a really nice arch in the proximal aspect of the foot. Minimal arch, no arch. So how can we apply this and make it work maybe even better? We teach the students at the California school to twist the plate even further. We tell them, don't just do what Mert Root did, push down on the first ray and maximally evert the forefoot on the rear foot. I wish you could see the look on these faces as I'm looking out in the audience. It's like, are you kidding me? All I can tell you is try it. Okay? Now, the first ray will not come down unless it needs to. That's my observation. If you do this on a cavus foot, the first ray doesn't go anywhere when you push down because it's already down. But if you do this on an adult-acquired flat foot, it drops down about 4 centimeters because it's way up and it needs to come down. So we twist the plate, and the plate will twist when it needs to. There's no way you can over-twist the plate. Trust me. So that's what I do when I cast every patient for foot orthotics, and particularly for plantar heel pain, because I believe that the more I twist the plate, the less tension I'm going to get in the plantar aponeurosis, and the better outcome I'm going to get with offloading and foot orthotic therapy. Now, there's tricks that have been used in the podiatric profession for years to improve function of foot orthoses. One of them is the reverse Morton's extension. This is thought to improve plantar flexion of the first ray, or improve weight bearing under the first ray. It really is a technique to twist the plate because it creates a wedge effect of everting the forefoot on the rear foot. In recent years, I have been doing this when I have a patient with plantar heel pain who's not getting better. And as I admitted yesterday, that happens not too unfrequently in my practice. I fail with foot orthotic therapy to cure my patients with heel pain probably 10, 20% of the time. And I know what happens with you. And we all sit back and go, why didn't this patient get better? And then we start speculating. Maybe they have an entrapment of the first branch of the lateral plantar nerve, all that. But you've already made this foot orthotic, and the patient comes in and says, I'm not any better. And sometimes they come in and they say, I feel worse with your orthotic. And that's happened to me, and I'm sure it's happened to you. And I'm convinced that when they get worse, it's because I inadvertently am supinating the forefoot on the rear foot. I inadvertently supinated the cast, and I made the forefoot now invert on the rear foot, and I'm overloading the plantar fascia. If they aren't getting better, I put a Kogler wedge on the orthotic, on the top surface. Okay? This is what it looks like. This is a right orthosis. And this is a Corax wedge, and believe it or not, it's 1/4 inch Corax. And I skive it proximal, distal, and medial. Okay, so here's a right orthotic, and here's the heel cup. And this begins at about mid-shaft of the 5th metatarsal, and it extends out to the distal margin of the foot plate. You can even extend it if it's a full-length orthosis out to the sulcus. And what this does is it twists the plate. It everts the forefoot on the rear foot. I'm amazed how effective this is, and I'm convinced at least 50% of it is placebo. Because I get these patients in who aren't getting better, and I go, I've got an idea, and I take it into the back office, and I put one of these wedges on. I take my time doing it, so they think this is really, and I bring it back in, and they walk down the hall, and 9 times out of 10 they go, wow, that feels a lot better. Okay? And that's all you need to do is make them feel better. Now, that's not a forefoot valgus post. I'm supposed to have a slide there, and I dropped it. If you put a forefoot valgus post on an orthosis, all it does is evert the entire foot plate. It doesn't twist the plate within itself. It doesn't twist the forefoot on the rear foot. Do you see the difference? A valgus post just turns the whole orthosis. No, I want to keep the rear foot on the foot plate, and I want to lift the forefoot on the rear foot. I want to twist it. The only way you can do that is do this on the top surface. Okay? Okay, I'm going to get to the surgery part here. Is Schubert awake yet? Are you awake, Jack? You're going to like this part. Okay? So let's move into surgery, and then we'll be done, and we'll go eat lunch. Okay? Is there any evidence that increasing pressure under the lateral forefoot, which is what we do with a Kogler wedge, will raise the medial arch or decrease strain on the plantar aponeurosis? And I say, look at studies of lateral column lengthening, flat foot surgery. And it's this surgery that's most interesting to me, the so-called Evans procedure or the lateral column lengthening. It's a very popular procedure, and it's also a very profound procedure. And it's always interested me where we can take a 1 centimeter wedge and place it right here in the calcaneus and profoundly change the whole posture of the foot. And it's this 1 centimeter wedge. How could that do that? Now, there's this theory that it swings the forefoot over. Not 1 centimeter wedge. There's no way it just swings the forefoot over. But it does profoundly change the foot. And the reason it does it, in my opinion, is it twists the plate. Because it ends up doing the same thing as when we put a lateral wedge under the forefoot. Okay? Now, I'm going to show you in a second why, but here's some studies done. This is up in Seattle again from our friends up there, Sig Hansen's group. And they showed, yes, profound changes in the foot. When you put this silly 1 centimeter wedge in the calcaneus, you change all these radiographic parameters of the foot in a favorable way. Okay? And here's a pre-op of a juvenile, or not a juvenile, but here's a pre-op mild flat foot, pre and post-op. Yes, they got a gastroc resection, but this is a 1 centimeter wedge in the calcaneus. Look at the difference. How can a 1 centimeter wedge do that? Okay. Well, we know that it doesn't just correct abduction of the forefoot on the rear foot, but it changes the talonavicular joint, and it raises the arch. It looks like all those things that happen when we put a Kogler wedge under the forefoot. Now, what we've learned from the Evans osteotomy or the lengthening is it increases forefoot varus, but it most importantly increases lateral forefoot pressure. It does what that wedge does. It raises pressure under METs 4 and 5. And in many cases, it creates lateral column pain if you overcorrect them, and it can even cause stress fractures in the lateral column because of the increased pressure you've exerted. But by increasing that lateral forefoot pressure, it reciprocally pronates the forefoot on the rear foot, pronates the forefoot on the rear foot. Another popular surgical procedure is the medializing calcaneal osteotomy. This study showed that as we medialize the calcaneus, we reciprocally increase lateral forefoot pressure. That's twisting the plate. Invert the rear foot, evert the forefoot. Now, we've also learned that lateral forefoot wedging certainly doesn't pronate the subtalar joint, as Kevin Kirby would always speculate. You put a lateral forefoot wedge under most feet, it doesn't cause the rear foot to pronate. In fact, as I showed you in my x-ray and in these studies, it actually supinates the foot. And it does so because of the effect on ligaments. And this is the final part of this lecture. This is what's so interesting is they've looked at this lateral column lengthening procedure. And they've tried to figure out why is it so profound. And Mosca speculated, I know why. I think it tensions the plantar fascia, tightens it, and raises the arch of the foot. But when Mosca did his study on cadaver models, they found the opposite. As they did the lateral column lengthening, they relaxed the tension in the plantar aponeurosis. Relaxed tension. Lateral column lengthening was shown to produce looser plantar fascia. Well, Kogler showed that. When he put a lateral wedge under the forefoot, increased pressure under METs 4 and 5, he reduced tension in the plantar fascia. Okay? So these are our favorite surgical procedures. I already showed that. And they've been studied extensively, both clinically and, interestingly, on ligament tension. This study by DeLand showed that when we do a medial displacement calcaneal osteotomy and twist the plate, we reduce tension on the spring ligament. But what about the other ligaments in the foot? This is an interesting, I'm going to move on to this, okay. This is a fascinating paper on the Evans osteotomy, again done up in Seattle, where they used cadavers and they created these flat foot models, and then they did this three-dimensional CT imaging to show the rotation of the foot as they did the lateral column lengthening. Okay? Really interesting, and showing all these changes and the rotation around the talonavicular joint and the calcaneocuboid joint. But what they learned is it's all right here. It's the long plantar ligament. That's where the changes are occurring. Okay? And this was brought home, and I'm going to just show you. This is the long plantar ligament. It runs just anterior to the lateral calcaneal tubercle. Now, people yesterday said, how do you treat people with lateral plantar heel pain, lateral plantar fasciitis? And I'm like, I don't know that I'm treating lateral plantar fasciitis. How about these people who have that plantar lateral calcaneal tubercle pain? Why not suspect they're getting overload of the long plantar ligament? Okay? And there's been elegant cadaver studies done on this, but now we go back. And this guy is a good friend of ours and a great contributor in podiatry. This is a great paper in a podiatric journal by Jeff Christensen and his group showing this vital role of the lateral plantar ligament and the Evans osteotomy, and showing that basically the reason that procedure works is it creates tension in the long plantar ligament. And it relaxes tension in the spring ligament. And so if you want to do an Evans osteotomy and make it work, this is interesting, you better have a functioning, intact, long plantar ligament. And it's that ligament that gets tensioned when we put a lateral wedge under the forefoot, and it gets tensioned when we do a lengthening of the lateral column with an Evans osteotomy. And it's that tension in that ligament that twists the plate and raises the arch of the human foot. Think about that. Thank you very much.